It's 10 minutes past your cutting time, and your 15-kilogram 1-year-old retinoblastoma patient has not arrived in the operating room for his scheduled eye examination under anesthesia. You call the ward, and nursing staff reports that the patient is late because they haven't placed an IV line despite multiple attempts. The surgeons are already fretting, so you order them to transport the patient immediately. As you wait for the patient to be wheeled in, you contemplate whether to attempt IV cannulation in an already agitated patient or to proceed directly with inhalational induction without IV access to facilitate the procedure. Good afternoon. I'm Marianne Orros, and I'm here to discuss a common dilemma. Is it necessary to gain IV access before instrumentation of the airway for pediatric cases? At the end of this session, I would have hoped to have discussed with you the value of IV access in perioperative management among children, as well as enumerate the difficulties faced in obtaining vascular access in young patients. To define difficult venous access and describe the technological tools available to facilitate venous access with their respective success rates. Using available data, enable one to make a rational decision whether to secure an IV line or not prior to airway manipulation in pediatric procedures. Establishing IV access is customary for patients undergoing general anesthesia, especially in the pediatric population. It has always been considered an essential part of safe anesthetic practice, with its purpose of intravenous administration of fluids, medications, chemotherapy, contrast media, blood products, and even parenteral nutritional support. Certain vascular access also allows drawing of blood samples and invasive hemodynamic monitoring. However, it can be quite challenging to insert a peripheral line in this subset of surgical patients. It requires great skill as it is not without its own risks and complications. Children have very small mobile veins and excess subcutaneous fat, making visualization and palpation difficult. This means that children are usually punctured several times in different areas, causing hematomas, ecchymosis, leading to deterioration of access sites, and pain that sometimes result in even more discomfort than the elective procedure itself. These situations result in physical and psychological trauma, not only for the child, but even for the parent and the healthcare staff. Yan et al. Developed a clinical prediction tool that would be easy to apply and be useful for predicting success or failure of peripheral intravenous line insertion in children. Their study assessed 16 candidate variables, ultimately developing a 4-variable proportionally weighted rule that would predict the likelihood of multiple failed IV cannulation. The output of this study was the DIVA, or Difficult Venous Access Score, an already externally validated tool which assesses venous visibility and palpability after tourniquet application, as well as the age and history of prematurity of the child. A score of 4 or more indicates 50% likelihood of failed catheterization on the first attempt, and that extra consideration may be needed, such as prompt referral to an appropriately skilled clinician, or use of available venous access aids in placing a peripheral intravenous catheter. There are several methods of improving venous prominence or locating peripheral veins. The application of a tourniquet is the most common technique to augment venous prominence, and it is applied proximal to the planned site of puncture. However, prolonged application for more than 5 minutes increases venous tortuosity and fragility and should thus be avoided. Slapping the skin firm enough to release inflammatory mediators that cause venodilation, but not too hard to cause pain and elicit a vasoconstrictive reflex, as well as milking the vein from proximal to distal, may also increase venous prominence. Most patients who come to the operating room have already fasted, are dehydrated, frightened and scared with a very high sympathetic outflow, and the operating room can be very cold. All these factors can conspire together and contribute to the significant diminution of the peripheral veins. Thus, the application of forced warm air or warm pads over the site of IV cannulation increases local blood flow that enhances venous distension. Gently wiping the skin with an alcohol swab may help visualization of the vein as the reflection of the light of the skin changes. Topical venodilatation may be achieved by application of vasodilation pastes that contain magnesium soak sponge or 4% nitroglycerin paste. This, however, is not recommended for cardiac patients. New and old technologies have been evolving to make the peripheral IV cannulation more successful. Of these technologies, the near-infrared and the ultrasound are the most published. Ultrasound-guided first attempt IV access success rate is commonly reported between 53 and 80%. Trifterer et al. Specifically studied ultrasound techniques for the great saphenous vein and reported success rates at 96% for younger than 6 months and 100% for older infants. The advantage of ultrasound-guided technique includes better assessment of all the possible locations for peripheral IV cannulation, ability to predetermine the size of the vessel, as well as to determine the depth of the non-visible vein. Furthermore, it is possible to predetermine a proximal curve or a proximal obstruction. This capacity to pre-screen can save time and costs by avoiding futile blind cannulation attempts and reducing the stress on the child and the parents. Transillumination system has evolved in safety and portability. The device is applied to the palmar or plantar surface of the hand or foot opposite to the site of IV cannulation. Hosokawa et al. Reported first attempt success at 73% with transilluminator and 49% without it. Atalay et al. Found success rates of 80% with patients identified DIVA and an overall improved success from 70 to 94% in children under 36 months old, showing this technology is most useful for small children. The near-infrared technology helps visualize the potential presence of a vessel that is not visible to the naked eye. Some of the NIR limitation includes the inability to gauge depths, hydration status, and the size of the vessel. This depth limitation makes visualization difficult for abundantly well-nourished children and anatomically deep vessels such as the cubital veins. Collective evidence of this technology suggests that it does not significantly improve success. Smock et al. Reported randomized patients to NIR versus no device and found no benefit. What is remarkable with his report is that the practitioners in this study were experienced IV team members who had twice times training in the use of NIR. But their first attempt success rate was even reduced from 62 to 47% when using the device. It is possible that in these cases, the light may even have hampered the cannulation. Going back to our case, in the absence of intravenous line, is it a safe anesthetic practice to secure the airway via inhalational induction in the absence of an IV access for a short procedure that is already delayed? There is good reason why most providers are anxious about taking care of infants and children. It is challenging and intimidating to open the airway of such a small infant when adult-sized fingers dwarf the size of the baby's mouth, and all of the instruments are smaller. The size, weight, anatomy, and physiology of infants and young children vary greatly from adults. Failure to modify medical management appropriate to the child's age can easily lead to complications. The American Society of Anesthesiologists closed claims analysis and the Pediatric Perioperative Cardiac Arrest Registry show that cardiac arrest and brain death in pediatric patients are still mainly caused by airway problems. The POCA registry found that respiratory events to 27% pediatric perioperative cardiac deaths that carry a higher mortality rate than adults, with laryngospasm being the most common cause. Laryngospasm most likely occurs when secretions, mucus, or blood stimulate the vocal cords in a patient who is likely anesthetized or in stage 2. Manipulation of the airway at an insufficient depth of anesthesia is also a major cause of laryngospasm. Based on Goodell's classification of the stages of anesthesia, stage 2 or the excitement or delirium stage is marked by disinhibition, uncontrolled movements, loss of eyelash reflex, and airway reflexes remain intact during this phase and are often hypersensitive to stimulation. There is a higher risk of laryngospasm at this stage, which is why any airway manipulation should be avoided. Stage 3, or the surgical anesthesia stage, is the targeted anesthetic level for procedures requiring general anesthesia. Ceased eye movements with constricted pupils and a central gaze and respiratory depression are the hallmarks of this stage. Airway manipulation is safe at this level as swallow and laryngeal reflexes disappear. Even attempts at IV cannulation should be done during this stage, as any painful stimulus applied during light anesthesia could trigger laryngospasm. Therefore, in the absence of muscle relaxants to completely obliterate airway reflexes, sufficient depth of anesthesia must be achieved before direct airway manipulation is initiated. Sevoflurane in the absence of muscle relaxants sevoflurane being a non-irritating anesthetic with low blood gas partition coefficient has become the suitable agent for inhalational induction in children. Several studies have aimed to determine the effective concentrations of sevoflurane necessary to achieve excellent conditions for the placement of LMA or endotracheal tubes during laryngoscopy without the use of neuromuscular blockade. Inumata, Taguchi, Antaa, and Krabowska performed studies on pediatric patients ranging from 1 to 12 years old, classified as ASA 1 or 2, scheduled for elective surgery under general anesthesia. These patients were induced via inhalational technique after saturating the circle system with sevoflurane. Initially, spontaneous respiration was assisted and then controlled manually. After end-tidal sevoflurane concentration reached a predetermined value, LMA insertion or laryngoscopy and tracheal intubation would then be attempted. The concentrations were randomly predetermined and obtained for each patient. It would be considered a smooth tracheal intubation if it was accomplished without any presence of gross purposeful muscular movements, such as coughing. Using a logistic regression test of data in the population of each study, the dose-response curve then revealed the ED50 and ED95 of sevoflurane that would facilitate a smooth placement of either a laryngeal mask airway or an endotracheal tube. The breakthrough pilot study of Inumata in 1996 identified 4.68 as the EC95 of sevoflurane when intubating children. This paved the way for studies comparing intubating conditions between inhalational induction with and without the use of neuromuscular blockade. Intubating conditions in these studies were scored utilizing various scoring systems. Most commonly used were the Helbo-Hansen scoring system, the Craig tracheal intubation score, or the Copenhagen Consensus Conference score. These scoring systems have similar variables such as the ease of laryngoscopy, the position of the vocal cords, jaw relaxation, coughing, and limb movements. Each variable was allotted as a score of 1 to 4, and intubating conditions were considered clinically unacceptable if any variable scored greater than 2. A higher aggregate score would reflect poor intubating conditions, while lower scores indicated better intubating conditions. In 1999, Thwaites et al. Compared intubating conditions between inhalational induction with sevoflurane to that of propofol with succinylcholine, using the Craig tracheal intubation score and the Copenhagen Consensus Conference scoring. Patient characteristics for the two groups were comparable except for gender. Based on the scoring system, overall intubating conditions were clinically acceptable in both, but individual intubating scores were better among propofol and succinylcholine group. The trachea was successfully intubated at the first attempt in all patients under clinically acceptable conditions, although excellent intubating conditions were higher in the propofol and succinylcholine group. Blair et al. In 2000 studied intubating conditions in 120 children aged 3 to 10 years old, comparing sevoflurane with propofol and succinylcholine, or propofol and alfentanil, using the Helbo-Hansen scoring system. Again, intubating conditions were clinically acceptable for both sevoflurane and propofol succinylcholine groups, with no clinically significant difference in the number of subjects. But the succinylcholine group, represented by the black bars, significantly recorded more individually excellent intubating variables. The only study comparing such among infants and children less than 2 years old was done by Davis et al. In 2010. They compared sevoflurane and placebo with that of sevoflurane and rocuronium. In this study, it was significantly apparent that intubating conditions were better in the rocuronium group, with clinically acceptable intubating conditions in 92% versus 63% in sevoflurane group. Adverse respiratory events were also significantly less in the rocuronium group at 0% versus 30% in the sevoflurane group. In conclusion, for children aged 1 to 24 months, the addition of rocuronium to sevoflurane improved intubating conditions significantly and decreased the frequency of respiratory events in this subset of patients. These observations, together with many others, confirm that intubation with neuromuscular blocking agents is feasible, but excellent intubating conditions are more likely when a neuromuscular blocking agent is utilized. All airway obstructions caused by laryngospasm can be terminated with a muscle relaxant, making this measure vitally important. So, why would one consider intubating the trachea without neuromuscular blockage? It is important to address this question to justify one's chosen technique and ensure that it is primarily for the patient's benefit. The side effects of rapid-acting succinylcholine are well described and range from inconvenient to potentially catastrophic. However, rocuronium is well documented in rapid sequence induction and can immediately be reversed with sugammadex, thus making it seem irrational not to paralyze prior to intubation. Certain neuromuscular conditions may cause difficulties in the choice, dosage, and reversal of neuromuscular blockers. In such circumstances, neuromuscular blocking agent-free facilitation of tracheal intubation may be logical and has frequently been used, for example, in patients with myasthenia gravis requiring thymectomy. There are some surgical procedures where paralysis is undesirable, such as when the use of a nerve stimulator is necessary to identify nerves or to confirm their integrity is required. For this monitoring to work, the neuromuscular junction must be functional at the time of by the time the stimulator is used. This may be achieved by reversing an initial dose of neuromuscular blocking agent and allowing it to wear off, or by the use of a neuromuscular blocking agent-free technique. There are times when the duration of action of a neuromuscular blocker may exceed by a considerable margin the operation time. Can the avoidance of neuromuscular blocking agents be justified in this case? Perhaps, but the availability of Sugama-dex allows prompt reversal of both rocuronium and becuronium well. Allergy to neuromuscular blocking agents is rare, but is real. Thus, neuromuscular blocking agent-free facilitation of intubation may be explicable in such circumstances. However, in practice, even when allergy has been convincingly demonstrated, an alternative safe neuromuscular blocking agent in the form of rocuronium may be used. In the extensive setting of clinical anesthesia practice, the use of tracheal intubation without a neuromuscular blocking agent in the absence of a good clinical reason would mean choosing an inferior technique for one with greater efficacy. The current era of evidence-based medicine is aptly described by William Osler, where medicine is a science of uncertainty and an art of probability. Often, we find ourselves on a precarious scale, weighing the risks and benefits of every clinical decision we make. In making these calculated risks, we bring to bear knowledge, available evidence, experience, our own and that of others, the individual characteristics of the patient, and the constraints of the service. Using one's clinical judgment, which is an amalgam of the above, would mean reflecting and scrutinizing one's chosen technique and whether it justifies the additional risk to the patient. Thank you.